cases, at which point they might want to know.
Okay, good to know. Okay, I think we'll go ahead and get started. Thank you for joining us today. My name is Heather Braddock, and I'm the Education Coordinator for the Great Plains IDEA CTR. Today, Dr. Cyrus Desouza will be speaking about patient recruitment and retention. He's a professor and chief of Diabetes Endocrinology and Metabolism Division of Internal Medicine here at UNMC. He's been the director of the VA Diabetes and Obesity Program for the past 8 years. He's been the PI of about 30 grants, has written numerous publications, and still makes time for community service as a physician volunteer for children's diabetes camps. Dr. Desouza has been the UNMC Distinguished Scientist Award and has received many honors throughout his career, including making the Doctors in America list more than one time. We are grateful to have Dr. Desouza with us today. Please give him a warm welcome.
Well, thank you for that introduction. I don't know whether I should it's on both sides. That's good. So, okay, we can get started. And, we'll I have a couple of case scenarios which we might spend a little longer time on because that may be more interactive. But how many people actually, are part of some sort of clinical study where patients are involved? Okay, good. So then that might be a bit useful. Okay. So we're going to just review some of the barriers involved in recruiting into studies with patients in them. We're going to discuss, what are some of the strategies to actually recruit well. And then we're going to understand retention long-term, because that's a different problem than recruitment. And then finally, discuss a couple of scenarios around that. So, the NIH is focusing on educating the public on this topic because 80% of all trials struggle to recruit patients. And, up to 20% of these trials, they are closed by NIH. So they're good ideas, but, if you have no patients, you have no research study. You could have the best idea in the world, and you could have a lot of money to do that, but if patients are not willing to participate, you're not going to find any benefit to that. So that is why NIH has taken up this mission to educate the public. Okay, so if you look at surveys sent out to the public, 32% of adults say that they would participate willingly in the clinical trial. 28% say they would consider it with some reservations. They're not sure about it. So you can see that's actually a low percentage of people who actually truly would like to participate. But if you educate people about research, it is found that these attitudes actually change. And to give you an example, so this is for the general population. If you do the same survey in the VA, which is a more, the veterans are more educated, they're more committed to their system, you'll see that close to 75% of them are willing to participate. The first question, and even another 15 are maybe a little reluctant, but almost 90% in some way would be willing to participate. So you can see that education matters. I mean, it's really important. Now, the number of papers that have come out regarding how to recruit successfully in clinical trials is approaching, a huge number of publications over the years. So what do we do first? So even before, starting a whole project, There are 4 things you should do is you should look at whether you have actually, enough patience for that particular project. Develop a recruitment plan, and this could be like a common, standard operating procedure for your division or for your group or whatever, that could be adapted to each different trial. Okay, good. And then you should make sure that you have a team that is committed to rolling out this. And then finally, obviously, when you talk to patients, you have to make sure they are receptive to this. So there was a study done, especially in minority groups, because it is very difficult to recruit minority groups. So how many of you have tried to recruit like Hispanic patients? Nobody's tried? It is tough because lots of issues are, surrounding them culturally, as well as, things like immigration, all sorts of things. So it's very tough to actually recruit Hispanic patients. And we want diversity in our clinical trials, because otherwise all we'll get are results for Caucasian people, right? We won't actually know what's best for African Americans or Hispanics or Asians or whatever else, okay? So we do need some diversity. So this study was looking at actually minorities, and they asked several types of questions about what is the barriers, what are the more effective strategies, what worked, what did not work, what was the reason some people signed up and then dropped out. So all kinds of questions were asked in the study. And then you can see this is some of the results of that study. The top 6 or 7 reasons are the most important. First of all is to develop a rapport with the patient, whoever is consenting the patient. So most patients said they didn't consent because they didn't establish a good rapport with the person who was consenting them. That means they felt discomfort in the discussion or inhibited to ask questions, or they felt like they were being hard sold, like when you go to a car salesman, right? So those kind of things. And then among minorities, compensation is important, because remember they are socioeconomically a little worse off than Caucasians. So we have to have a right balance between coercion and the right amount of compensation. Because you can see that is important to them. This is from the patient's perspective. Many times IRBs say, well, you can't give them so much. But then you have to say, okay, what is the difference between coercion and compensation? For example, a patient is coming in for a visit that takes 35 minutes. So for travel and his time, maybe $25 is $30. That's fair compensation. But on the other hand, if the patient has to come in doing a procedure that maybe it's not invasive, but it takes 2-3 hours, okay, imaging or something, well then you can't give the patient $25 and expect that to be a wonderful compensation. So the compensation has to be dictated by that. Somebody coming from 2 hours away, maybe needs more travel compensation. So all those provisions should be upfront in your RB application. Then it's always found that if a person knows somebody else participating in the study, it's a huge help. So a lot of times, the lack of knowing somebody else in the same study can actually lead to a problem in recruitment. Then, of course, socioeconomic and education level is important. Lack of education, meaning even lack of interest because of lack of knowledge of what research is all about. Of course, the age-old time commitment. If you're retired, maybe you'll have some time. But, people who are working, they may not have time. So those are the major, and then there is the whole list of stuff, but those are the major components of the challenges. Now, if you look at it from the perspective of the investigator, so we were looking at it from the perspective of the patient, right? So if you ask the investigator what they think are the main challenges, then you can see they'll say lack of awareness and about clinical trials in patients. So about almost 60 to 70% of the patients, which is the first column here, red and blue, don't know much about clinical trials. So that's a problem. Then complexity of the protocol. So if you make a protocol really complex, you have to come 50 times and then you have to titrate this insulin every other day, and then you have to call every 15 days, and it gets, and you have to do all these surveys in between. The more complex you make it, the more challenging it will be to patients. And then lastly, social and cultural issues. For example, I give you the example of Hispanics. Their culture is that you go to the doctor only when you have an illness. They have no concept about what preventative medicine is. So if your trial is about preventing something, then you're going to have a problem, because they're like, well, I'm not sick, So that is a cultural barrier that you need to educate the patient about. So that's one of the things. Okay, so I went over this, the problem with recruitment is that 80% of trials are either not recruiting to the timeline or not recruiting the number of patients needed. So they've actually developed this equation called clinical trials participation equation theory. It's a balance between, so the willingness to participate is a balance between several things. The top part of that equation over the white line is the positive things, and below the white line is the negative things. That's why I put it in orange or red. So, education, awareness of research, credibility of the institution. If they in their mind have it that, UNMC is a really good education place, or it's a good place where research happens. Local TV show research. If you've looked at news, they do show from time to time. So if your institution is one of the institutions that people relate to in terms of, like, they're doing a lot of research and good for our community, then that's a good thing for you right off the bat. Okay? We talked about communication between the person communicating with that patient in the first time, which is really important. And then all the resources available to the team trying to recruit. That's really important from the institution. On the flip side, what is the risk of the study? The real risk, because you have to explain the real risk to the patient. If there's a lot of risk in your study, naturally, a lot of patients may say no, okay, because who wants a lot of risk, right? But some studies come with a lot of risk. Now, just let me take oncology, for example, okay? Patients accept a higher risk profile because of the type of disease it is, okay? They're willing to participate in a research study that has a much higher risk. Then say, I'm going to prevent diabetes or obesity, but the risk has to be low, because patients are not going to be willing to take a very high risk for that, okay? Because it's something that's going to happen in the future. They don't have it yet. So, you have to see what is the risk relationship. And then, of course, inconveniences. If you tell them you have to come every month, fasting for 14 hours, you cannot do this, you can't have your coffee, whatever. You've got to call me every week. The more complex and more things you make the patient do, you're going to have your measure your blood sugar 6 times a day, every day for the 3 years from now. No. Impractical, right? So all those kind of things do play into how your recruitment will be. Now, key thing is healthcare providers. Shown that if a patient is asked by their primary care provider to participate in a study because they think it's probably going to be beneficial to them, or it's something that would be helpful, not necessarily to the patient, but in general, the patient will probably respond positively. 75% of them would accept in a study that was done. Even with the fact that when those 75% of the patients were asked, what exactly did the provider tell you? Most of them said they just said this is really good study, you should participate in. That's it. Only 32% of the patients said that there was a detailed explanation or somewhat detailed explanation of what the study was and all that. In spite of that, 75% participated. So the relationship between the provider and the patient and the trust is paramount for initiating their desire to be in a study. Okay. Now I'm sure you all know about the inverted pyramid of recruitment. We all probably are quite familiar with this concept. So you have what is called the accessible population. That means all the population that exists within a system. So for UNMC, everybody in Nebraska Medicine in UNC, say the whole system, okay? That's your accessible population. But not always do we have access to everybody, right? So then the question comes, who do you have ethical access to, right? And many times the IRB determines that. I just want to spend a couple of minutes here or two, because depending on how important your study is, what your study is asking, and the general relationship of that study to UNMC, the IRB could grant you access to all patients. It doesn't do that often, but you could request for it. I'm just telling you there is an option. So, for example, I have a study, it's called a GREAT study. We required such a population that unless we recruited from the entire pool, we would not be able to, have 250 patients in it. So, the IRB was requested, there's a form, and there's a procedure, but we do have that access now. Okay. Then the second level of access is to what is called an opt-in list. Have you all heard of that? So you could request the Vice Chancellor of Research's office that patients who opted in to be invited to a study. So when patients come in, they get a form saying, would you like to participate? Would you like to be called about a study in the future if something that is suitable to you comes up? A general question. And about 65% of patients answer yes. Okay? So that gives you access to about, 65%. But again, that's not available for every study. It's available to people, studies that are deemed important and, all those things. But that's another avenue. Then, once you decide what is your eligible population that you can withdraw from, accessible population, and you see how many of those actually meet eligibility criteria of your study, right? So that drops down the number of patients who will actually eligible. Then from those, you invite the eligible patients, but then how many want to how many are interested? So maybe 5 out of 10 may be interested, and then out of those 5, maybe 2 or 3 will consent. Okay, so you're going to drop down further in your pyramid. And then you screen them. Many times they don't make the screen because The LFTs were normal last month, but suddenly now they're not. Or some lab was really fine and now it's not. And they can't be in the study right now. So some of them screen fail. And then you get the absolute tip of the pyramid, which is the randomized patient, right? The golden goose egg. So you have to do a lot of stuff to get to that one patient that you randomize. And I think for every trial, what you need is a plan, a flow plan. Okay, don't read into it. I don't need you to read that. It's just you need to come up with a plan. Okay, how many patients, would it take to get from here to there? Okay, you need to have a plan. So it should have a identification phase, a screening phase, eligibility phase, and a randomization phase. This is just I picked up from one of the big diabetes trial called the LIFT trial. They actually had an accessible population of 5,122. One would think, oh, huge, right? But in the end, they randomized about 260 people from that population. And believe me, theirs was not that complicated inclusion criteria, okay, or exclusionary criteria. So that you can imagine for my great study, which I needed 200 and something people, I needed that access to the whole population. Similarly, for each of your studies, you need to figure out what should be the accessible population for you to get the number of randomized that you want, okay? And depends on your experience a little bit too, because more complicated trials, it's going to be, the pyramid's going to look like, like that, like a small tip with a huge base. While if it's a more simple study, you might have a better flow. Okay, so what are the sources of subjects? Like how can you identify your subjects? So, you can do chart reviews from the subjects that you have ethical access to, or if you request the RB and they give you permission for a wider access, then you can query the database or the electronic medical record. The difference is a database is a collected group of patients. Like you have a database of diabetes patients, you have a registry of cancer patients, you have a registry of whatever, okay? So registries and databases are one type of electronic record, and then there's the actual electronic medical record that you could use. Of course, you would need IRB permissions for that. Then you have referrals. Referrals means your primary care physician referring the patient to you, like we discussed a little bit before. Then there's advertising. That means you advertise via radio, newspaper, Google, Facebook, social media, all those kind of things. Anybody use social media? Yes? Now, different studies will produce different results in that, and we're going to go over some of that. So if you look, the top part of the chart tells you the actual, yield. That means out of every, say, 10 patients referred by that method, how many actually get randomized, percentage. It's not too different. They're all hovering between 15 and 28%, as you can see. Although they look different, but they're hovering between 15 and 25 to 28%. So the yield is not that great, except maybe the referral is a little higher. We already discussed that, primary care physicians referring that patient, you will produce a higher yield. That means the patient is more likely to agree. However, yield is not everything, because it's not the total number. It's how many patients do you have in a particular system. So, for example, the bottom one just tells you in the same study, what is the actual final number of per patient, a percentage of patients yielded by each method. So you can see the EMR, or the electronic medical record, by far was the largest, okay? It yielded up to 60 to 70% of all the patients. while the other methods were much less effective. You can see like media was really low, okay? So very few patients actually got enrolled via radio or TV ads or even social media. Not every study is same, and every study might have a different response. So you have to see for your study what would be the most appropriate methodology. The other thing we have tried even here is, because we know that physician referral systems are really important to the patient, we created a prompt. The yellow thing you can see there is a prompt. So whenever a patient that was eligible for a study, and if the physician opened their record, and it was only directed to physicians or providers, mid-level providers, this thing would pop up and say, your participant may be eligible for this study. Would you be willing to ask the patient, and would the patient be willing to hear more about the study? Okay, this is not consenting. This is just initial interest. And there's a button, yes, no. Okay, and if you press yes, that patient's information goes to the coordinator responsible. Okay, so it was kind of in theory it was a very nice system, right? But how do you think it worked for us, at least?
Sure.
You think it worked?
Yeah.
What about you? Well, in the beginning it didn't work. Why? Any ideas why?
Fatigue with the messages that were popping up.
Yeah. So, physicians get all sorts of pop-ups. You've not done the A1C in the last 3 months. You've not, whatever. They just ignored it. They just completely ignore it. And if you ignore it, it doesn't pester you. This kind of is not mandatory. Means it does not prevent you from doing anything, nothing like that. So it's optional, so you can just ignore it and nothing will happen, right? So most people just ignore it. We had to go out and do some lot of education with the primary care physicians. There's a study there, it's going to be useful. And then we started getting some responses, but still not the most effective, okay? The problem with this was also that after a while, people started just pressing no, because they didn't ask the patient. They didn't, they just wanted to go away. So they would press no, and the problem is the IRB interpreted that as the patient does not wish to be contacted again. Then you put yourself in a big problem, because now the patient has never been asked about the study, but everybody assumes they don't want to participate in it. And there are a lot of these, because it's going through the EMR. It's asking every one of your eligible patients, okay? So think twice before implementing a particular strategy, okay? Because you can see that some strategies are, you're going to have to test them. Always do a pilot test. Because you don't want all your patients to be involved in the test, and then if it doesn't work, you're done, okay? So then, advertising. Advertising has to be done very carefully. You can't advertise that I'm going to give you so much money, okay? You can't say that. You can say add compensation for travel or something like that, But you can't say I'm going to give you $500 if you come into the study. Okay, then you can't say, this is a fabulous drug and it's just going to cure your diseases or something. You can't use that language. You have to use the language that this is an experimental or research drug or investigational. Most people don't know what investigational is, so you have to use a simpler word. So things like that, okay, for advertising. Okay, let's decrease the boredom here for a minute. Let's do a case scenario. And let me open this up also to remote sites in case they wanted to pitch in, for the study. So this is a 55-year-old lady, Miss Davis, and she's interested in a type 2 diabetes study that she's heard from a primary care provider. And she's now in your office. Like, that's a major first step to get them into your office, right? To go over the consent form. So after some minutes and explanations and all of the study design and what's going to happen and blah blah, Mrs. Davis says, "No, I'm not sure if I want to participate in a study where I have a 50% chance of getting a placebo. Okay, what could it do me if I'm on a placebo?" And now, how do you respond? Any ideas? What have you told your patient? I'm sure they've
Any
asked
type
you
of
this.
specific oncology? Are they saying certain type of cancer?
This is for any study. Sorry, I didn't get your. Are you
Those are
referring to
very, very
oncology? I mean, this
broad.
is anything. Any study could be for oncology,
No, because it's,
diabetes,
I mean,
infectious disease.
I can take them, but they're going to,
I think we're.
if I'm talking specific surgery or specific radiology, I'm going to need more information from them.
Okay.
Does that make sense? Sure.
Maybe the remote wasn't a good idea. Sorry, I think we've crossed our wires here.
Hello, this is Deb. Hello.
Hello?
I am work in the research subject advocate office.
Oh, I see. Okay.
I
We all got a wrong impression here. Sorry, go ahead.
Introduce yourself and ask if she won. Yeah. Deb Meyer.
So this is Dr. Desouza here, and we are discussing a case.
do they need a name?
Sorry?
Okay.
Deb's not listening to us. She's on the phone.
Yeah.
Okay. Let me try to disconnect.
Oh.
Okay.
I'm
like,
worked
okay,
on having a
it is a
patient name
research
for anything.
person, but
Um,
all right. So
so the patient that
Woke up
you're
people
currently
went
treating
awake,
is
right?
on a clinical
So what do
trial
you
of.
think?
Okay.
Because this is a very common question, in a
Yes.
clinical trial.
Okay.
Almost always have to have some sort of a
Okay.
control or placebo.
You could say that at this point, that's why you're conducting this study. because
I've
we
got, so
don't
Dr.
know
Reed's
that
on a
one
couple
arm
of
is better
cases.
than
Do
the
you
other.
have a
And in fact,
title?
it may turn out
What
that
type
the
of surgery,
placebo works just
clinical
as
trial
well
it
as
is?
the
Okay.
question you're trying to answer. And then, of course, that's at the level she wants to know what's good
Trials
for
of
her.
Dr.
But you could talk about the impact on
See if I can
society.
find it.
Even though it may not benefit you directly, depending on the results we find, it may change treatment for people that are coming
Right.
after you.
Any other ideas?
Okay. Okay.
So you.
Following that,
Yeah.
you can say,
Okay, I've got
turns out
19
to be
trials.
pretty
Crap.
effective treatment, then maybe we can get back to you and talk about that as an option.
I am going to,
Participate in your
So they
panel
always have the
I am going
option
to
of,
get,
if they feel that it's not benefiting them, to opt out, right?
Right, just because she's on placebo at this point.
I'm going to try to get someone from Dr.
Okay. So I'm
Reed's
listing the first 2
coordinator
points is
to
exactly what
hunt
you
someone
said.
down.
You first,
This is a
you feel
breast
they're
trial.
altruistic.
Okay.
In the sense, oh well,
Who
it'll
should I
benefit
have them call?
society, all other people
Patty?
with cancer or diabetes or whatever, like you have, in the future, if you participate, it'll give us answers and help people down the line, your kids, all that sort of stuff. Altruistic nature, okay? A lot of people respond to that, okay? Secondly, what you said, we don't know, this could be a benefit, it could be a risk, and possibly either
So
side.
you're an RN
That's
who
why
works
you're
in radiation
enrolled in the study,
oncology
and
at St. Joe,
so some people,
and your
they
number
get
is
used to their logic,
816-271-7280.
But there's a third line
And
of approach,
is there by chance I could
which
have
I
the
would like to
first
bring up,
name?
which is the benefit of actually being in a study. Many
I will
studies
see
have
history
shown
of
that
Angela
if
and
you're
have
part,
them
if
have
you're
them
part
get
of
back
the
to you.
study, your health care is far better, you reach better outcomes than the general population, even on a placebo. Just for example,
I just don't.
say
I just.
you're
I,
in
I
a
don't want to send
diabetes
you on a
study.
wild goose
They've done
chase.
this in many studies. And you're getting either standard of care or standard of care plus an investigational intervention.
Let me get back to you.
It could be behavioral, it could be a drug,
Bye-bye.
it could be anything, okay? But what happens is, even the placebo group, or the group that is standard of care, they actually receive standard of care, okay? Which is uncommon, because unfortunately, less than 10% of patients in the general population receive standard of care for their disease, okay? So even when they receive standard of care, they actually have better outcomes, okay? So you need to tell them that, Studies have shown that just being in a study because we are, the doctor is going to do physicals on you regularly, they were going to do blood tests regularly, all for free, mostly, okay? This is the advantage. We're going to check you, you're going to get advice from the doctor about your health more frequently. We're going to monitor, everything closely. And we're going to do everything if your disease is out of control, except give you the investigational drug. We're going to do everything that we have in our power, like all the tools available. Okay? That, I feel, is the most convincing argument for patients. Believe me, in my experience. It is the most powerful motivator. Because they say, oh, I'm going to see an endocrinologist or an oncologist every, couple of months. They'll answer all my questions. They'll be monitoring my labs. I like somebody who will, make sure my diabetes is under control, or whatever it is that you're investigating. Okay, whichever disease.
Dr. Desouza,
Yes.
could you please make an announcement for all remote sites to mute their microphones on their computers? Just because other people listening can still hear them, even though we can't.
Okay, let's do that. Can all remote sites mute their applications or whatever, computers, cell phones, etc.? Okay. So those are the three things that we could, talk to the patient about. So then comes subject screening. I'm sure you're all familiar with this, but it's really important to follow a process of subject screening. So history, physical, medications. These all help you to look at the exclusionary criteria that you have for each study before you actually randomize the patient. Okay. Now, scheduling subjects. Now, this is a very important issue for patients because, yes, we all work from 8 to 5 or whatever, but patients work from 8 to 5 too. Okay? So to tell them, especially if your study has a lot of visits, in-person visits, that's going to be problematic. Imagine you taking vacation, sick leave or whatever it is all the time from work, okay? They're not going to, do it. So options should be available. After hours, before hours, Saturdays. Now, of course, we don't expect our employees to be here every Saturday, okay? Or every day at 6 o'clock in the morning. But when a patient asks, like, can I come in, because there's so many times it's possible to come in, you should try and say, yeah, we'll try to arrange for that, okay? So that's another thing. Phone call visits can be made after hours, which would be more convenient for the patient. So be flexible, and reminders, because people forget. Even I forget my appointments with my physician. Reminders are real important. So, and let me tell you the generational problem about reminders. Young people, I have a couple of studies where they are young diabetes patients, like type 1, no matter how many phone calls or emails we send them, they don't get reminded. Guess what reminds them? Text. The only thing that they get reminded by, okay? A text, okay? Only text seem to work in that subgroup of patients. So, it depends on each patients. Rural patients, they don't have emails, okay? They don't sometimes even have a smartphone, okay? So you're gonna have to figure out, each patient, what is the best method to remind that patient, okay? So that's important. Okay, we'll move on. We don't have too much time, but we'll move on to the topic of retention. We were doing recruitment now. Now, once you recruit, retention is as big and important a problem. Okay. Okay. So if you ask patients, why they left the study once they already joined, probably a lot of the problem is fear of side effects. Okay. Not necessarily related to the drug, okay? But a lot of times, you do have to go through this enormous list of possible side effects, right? Every drug, if you look at the FDA sheet, how many side effects do you think an average drug has?
15.
Oh no, over 50 side effects. Everything you could imagine. Okay. Now, those are not the main side effects. I mean, they usually don't occur, okay? But the top 4 or 5 are the ones that you discuss with the patient in detail. And you do have to sort of quickly go over possible. It's 1 in a million, but yes, you could get cancer. Okay. But the thing is, the problem is, so once they start the study, every imaginable side effect in their mind becomes due to the drug. Okay, some things that they've had for years, now that's aggravated because of the drug. Okay, so you have to deal with that. Okay, it is a communication issue. You have to say, can we try to stop the drug and restart it, maybe to see if it's truly due to that. Okay, so things like that. Then change in the subject's environment. That means subjects change that they moved away from Omaha. Okay, their loved one became sick and they have to take care of their loved ones. Okay, they became sick so much so that they can't do the study. So those kind of things, happen. Life happens, right? And that is part of the reason why some subjects drop out. Experiencing an SAE which they feel is due to the drug, a heart attack or something. Okay, they say, "Oh, I think I got that heart attack because of the drug." May have nothing to do with it. Okay. Then there is obviously procedures. If you have biopsies, for example, or something that they did once in the beginning of the study and they know they have to do it twice more, I'm like, that is not going to happen to me again. Okay. So that is another reason why patients drop out. And then some patients are just they lose interest over time. Okay. They just become poorly adherent to the protocol and just that's a lack of interest. So I've listed some here statistics here. Center Watch is a center that actually follows some of these statistics in trials, and they reported a dropout rate of between 15 and 40% and an average of 25. That's a huge problem, and I'll tell you why in the next slide. And the common reasons, we already went over some of the common reasons. One of the things that we didn't discuss is, well, my diabetes is not improving in spite of being on the trial. Well, yes, but you gained 20 pounds and you just told me you came from a cruise. That's not going to help your diabetes. But that's not what they're saying, okay? What they're saying is, well, you told me in the beginning that I'll do well with my diabetes if I'm on the trial, right? Well, it's not happening. So, that sort of thing can happen too. Okay, so why is retention so important? I mean, it is really important. Okay, let's take this example. Say drug A versus drug B. They want to know for a heart attack which drug improves survival more? Simple question. After a heart attack, when we admit a patient to the coronary care unit, does drug A increase the survival or drug B 5 years after that MI? Okay? They're following these patients from the coronary care unit all the way to 5 years. Okay. We randomize 100, okay? Drug A, drug B. Now, drug A, after 5 years, they found that 15 patients died and 85 survived, okay, after 5 years. So what is the survival rate? Okay. And then drug B, what happened is that 8 died, 72 survived, but then 20 patients completely left the study and then they didn't know what happened to the patient, okay? They got totally lost to follow up. That means you don't have any information at the end of 5 years what is happening to those patients. So the first case is pretty simple, right? The survival rate is 85%. Everybody agrees?
Mm-hmm.
What do you think the survival rate in the second one is? Or what do you think the FDA will, what do you think statisticians in the FDA will tell you?
90%.
So one would think here the survival rate is how much? One answers 90%. Why? Because 8 out of 80 people died, 72 out of 80 people survived. That's 90% survival. Does everybody think the survival rate is 90%? And therefore drug B is superior to drug A. No? No, but that's not how the FDA is going to look at it. They're going to say, because we don't know anything about those 20 people, we're going to assume they died. That's what they're going to assume. Okay? That's how biostatistic works. And because of that, your survival rate will drop to 72% for drug B. Now see what happened? So you spent all these millions of dollars, and what happened? Because you lost track of 20 people out of 200 people in your study, all the millions that you spent is for naught. Okay? So that is why retention is so important. Every single patient needs to be retained in the study. And I'll show you the steps of retention. This is called retention strategies, obviously, confidence of the patient in you, listening to the patient's problems, being as convenient as problem in the scheduling, maintain the positive attitude and know the protocol well. But in this scenario, there are lots of factors. I'm not going to go all through the whole thing, but look, what could we do? We could call them in between. Just say, hi, nothing to do with the research, just seeing how life is treating you, things like that. Happy birthday, it's a card for you. These kind of things tell the patient your only concern is not the study, okay? That you're interested in as a patient too. Some tips, my coordinators actually write down, this is from a study, but I'm giving a little bit of my experience, but they write down things about each patient. Oh, this patient's daughter is getting married in 3 months, so next time when she comes, I'm going to ask her how was the wedding. Talk a little bit about that, This patient said they were going to Europe for the first time. I'm going to ask them, how was their trip? Or that patient, had a really, sick son or daughter and was trying to take care. Let me call them and inquire how they're doing, although the visit is not for another 6 months. Every patient, you should have 2 or 3 things that are unique to that patient. Talk to them about it, okay? I cannot tell you how important that is. That is the only way the patient feels that they are personally concerned about you and not only the study, okay? So those are some of the tips. Of course, there are other things like fair compensation, flexibility. We've said that again and again. But over and above that, this point is very important, okay? How to maintain your relationship with the patient. Because then the patient starts to feel a little bit of obligation towards you too. Oh, so-and-so is a friend of mine almost, and it'll be not that great if I just not go for the visit, They have some sort of pressure because they feel that pressure then. Instead of like, oh my God, there's another hassle, like I'm going to have to go for that again. So that's what's called barrier reduction. I just said it very quickly because we're running out of time, but you could see, this is a study actually where each one is listed, but generally that's what you do. See, what are the barriers for that patient? And how can I remove those barriers for that single patient? And remember, barriers for one patient is not the same for the others, okay? Okay, let's end with actually a case. So, Mr. Smith, who is 46 years old, enrolled in a study, and he's in a randomized placebo-controlled blinded study, so they don't know what's going on exactly. He comes in and says he's having too many side effects from the intervention, and he would like to not do the study anymore. Okay, common thing, can happen. So now, how do you approach them? What are you going to tell? Oh, how are you going to approach this? He's come and told you this.
Well, you figure out what kind of side effects it's going to be.
Okay, he tells you, I have nausea, my back is aching, this and that. I feel all of them are related to my medications. They may not be, but he feels that. So you be the patient and tell me, I'll tell you how to. So then I'm going to say, what? My next step is, okay, if you feel that, would you like to maybe see whether that's true or not? How about you want to say, discontinue the study for, the intervention, whatever it is, a drug, maybe for 2, 3, 4, 5 weeks and see if all your symptoms go away, all right? How would you like that? What's the possible answers? Okay, maybe I'll consider that, yeah? And maybe we can restart it if you wish and see whether those things come back, okay? A lot of patients will accept that, okay? I would say the majority, to try and see if that's really the reason. Well, say our patient is real stubborn and says, I don't know. I've tried that in the past. Oh, you tried it already. And, he got the side effects again. And now he says, well, now we know that I'm getting some of my side effects. I want to not do the study anymore. What is your option to tell him? What's your next option? Now, say, truly maybe it's the side effects of that drug. What's the next step? Well, don't take the drug, but please come for all your study visits. Okay, we'll take care of you. Like your normal, doctor. We'll do all your stuff. We'll do everything for you, even though you're not taking the drug. But you please come for all the visits. Because remember I showed you what happens when patients drop off? So you need to know what's happening to them. Okay? Then he says, well, I'm busy. I have life problems. I have to get a job. I'm like, you have to come 5 times a year. And, I can't do that. What would you say? You bargain with the patient. Do you think you can come twice a year for the 2 important visits where we do all the tests? For your safety? We want to know you're safe. Do you want to come once a year? No, not really. I don't want to do that either. Okay, would you be okay for a couple of phone calls a year where we can ask you some questions? Yeah, I don't know. Maybe not. Okay. All right. Would you be agreeable for us to contact your PCP and ask for your vital signs at the end of the study at least? Almost all patients say that's okay. As long they don't have to do anything, okay? Okay. So that is the way you don't even lose one patient. Because remember, you have to get the outcome at the end. What happened to the patient? If you have access to the medical record, you should be able to get that answer. Okay? So I've listed that. We have a form. You should make a form. There is a form. It's called the de-consenting of a patient. Okay? There are steps. The way I just told you, you go through each of those steps to see what level of participation is the patient actually willing to remain in the study. So discontinuation of full participation, discontinuation with partial, all the steps that I told you. Am I willing to just discontinue the drug? Am I just willing to come for the visits or some of the visits, only phone calls, maybe just the last study visit in the thing, or maybe just following your medical record. Okay. So the last thing is complete withdrawal of consent. Like complete. Like never look at my records, never talk to me again. Unless you've really done something bad to the patient, most patients will not reach that level. Okay? So really you should not have withdrawal of consent. And you will see that most of these large studies, the withdrawal, the actual completion rate of the study is above 98%. That's impressive. The last huge cardiovascular outcomes trial had 11,000 patients. Do you know what percentage completed? 99.4.
Wow.
That's a huge task. But why? Because all sites were trained on how to do withdrawal for the patient. See, that you need to know how to do it. And then you'll be able to do it. Remember how important it is to actually be able to do, retain all the subjects. Otherwise, you'll never get an answer to your question. Okay? So if you want resources, this is a nice website actually. You might have seen it on NIH, and gives you lots of resources for the researcher as well as the patient. Strategies and all that. So you could look it up. Any questions since we are out of time, Sarah?
Is there a source for the material on the stopping or the de-escalation you just had?
Well, the source could be us if you violate it. I don't know of an actual published source. You know what I'm saying? Mm-hmm. It's done very commonly in these large trials. So we could, share with you one of those forms and put it on. Maybe I'll ask Jennifer Larson where to put it, or Luann Larson.
Yeah.
So that people could use it as a resource. I think it's really important because, de-escalation of withdrawal of consent is a very important topic.
Mm-hmm. Thank you.
All right. Any other things, clarifications? All right. If you want, you can also email me. I'm on the, UNMC email system. And these slides could be distributed. It's not like propriety or anything. So.
Thank you very much.
Thank
you.
Yes.